Good morning, everybody, and welcome to our briefing today. This is a briefing where you have the opportunity to be taken through and discuss the final advice that was presented to government from Christine Morgan and the team regarding the National Suicide Prevention Taskforce work. As many of you will know, in our sector and beyond, that for a number of years we've collectively been advocating for a whole of government and whole of government's approach to suicide prevention. And with the support of Minister Greg Hunt, that message was taken to the Prime Minister about 2 years ago now and heard. And with that came the appointment of Christine as the Special Advisor to the Prime Minister on suicide prevention. A lot of work has been going on through the communities, through academic sector, through the clinical sector to really bring together the best advice. But the strongest advice that we sought was that of the lived experience community. So today we will be taking you through all that work and the report and its recommendations. Christine Morgan, as the Special Advisor, was joined by a team, a task force to help her in that work, and that team was led by Dr. Jaylee Skean and comprised of great people from many agencies and departments across government to inform that work and lead that together. In addition to the work of the task force, we had an expert advisory group that I was very pleased to chair, along with my colleague and fellow Commissioner, Alan Woodward, and a number of other experts from across the field, experts through lived experience, experts in the clinical setting, academic experts, community health experts, a range, and they're all listed and thanked in the body of the report that you now have available as it was released just last week. The real aim of the work that was undertaken was to develop a great shared understanding that could put the voice of lived experience along with academic knowledge, with clinical knowledge, with community knowledge, to inform an approach that was a whole of government approach to suicide prevention and really aimed to better connect our mental health system with our suicide prevention system. We've worked with communities, with our Aboriginal and Torres Strait Island communities, with our CALD communities to really try and shape the evidence and the recommendations that are presented for you today. The final advice comprises of 3 reports, the first of which is Compassion First. And we really think that this is a groundbreaking piece of work that brings together that voice of lived experience to really articulate the needs of that community, but also what it might be that will work to better support people in the community as well. There is an outline for the whole of government approach and systems change, and we'll be hearing more about that today. Particularly, Christine will talk to the 8 recommendations in the report and how we can all work together to save lives. Alan Woodward will then be taking us through ways that we can upskill government agencies and portfolios to deliver better services, life-saving services into our community. We'll wrap up today with a panel discussion with a number of members that are here online today to share with you. If you do have questions, we would be encouraging you to put them into the Q&A or chat functions that are available on Zoom as we go, because there'll only be a short time for questions at the end, but we do undertake to answer all the questions in the chat after the end of the session. Please note that the session is being recorded today, and I thank you for your participation, and I'm very pleased to welcome my friend and colleague Leilani Darwin, who is going to provide both an acknowledgement of country and an acknowledgement of lived experience. And then after that, we'll be hearing from a colleague from the expert advisory group, Graham Holdsworth, who will share his contribution from the lived experience community to the work that's being presented today. So over to you, Leilani. Thank you.
Thank you so much, Lucy, and good morning to everyone, wherever you might be in this beautiful country of Australia. I would like to acknowledge the traditional owners of the land of which we are all meeting on today. And for me, in Ipswich and Brisbane, that is the Yagara, Jagara and Nurrabu people, and pay my respects to elders past, present and emerging. In particular of note for me, I'd really like to acknowledge the many paths that have been paved by my ancestors and my elders so that I may be present today and do this acknowledgement of country and have a voice at the table and participate to the work that we're all collectively doing together. I'd like to also acknowledge Professor Pat Dudgeon for her continued leadership and excellence in suicide prevention and mental health, and acknowledge the mentoring that she has given to me and part of her work as this task force as well. For me, it's really important to acknowledge lived experience, and some of you will be aware of the work that we're doing at the Aboriginal and Torres Strait Islander Lived Experience Centre. I'd like to start off with the working definition that we have now in place, and this was created as part of a genuine co-design process over the past year or so. A lived experience recognises the effects of ongoing negative historical impacts and/or specific events on the social and emotional well-being of Aboriginal and Torres Strait Islander peoples. It encompasses the cultural, spiritual, physical, emotional, and mental well-being of the individual, family, or community. People with lived or living experience of suicide are those who have experienced suicidal thoughts, survived a suicide attempt, cared for someone through a suicidal crisis, been bereaved by suicide, or having a loved one who has died by suicide. Acknowledging that this experience is significantly different and takes into consideration Aboriginal and Torres Strait Islander people's ways of understanding social and emotional well-being. I'd also like to acknowledge the varied experiences that we all bring. We have paid a great price to have lived experience of suicide and mental ill health, and I'd like to pay my respects to everyone who continues to have courageous conversations in sharing what at times have been failures of the system and responses that we've received in our communities, but more broadly as well, the things that are working and what we can do together to move to address the issues that we're facing and the challenges. And I am so grateful that we have the work that has been led by Christine and everybody else in the task force and Jay Lee to ensure that the experiences, expressions, and I guess stories of people with lived experience are shared and really elevated as part of this work and the recommendations today. So welcome and thank you very much.
Hi, I'm Graham Holdsworth, and I had the privilege of being a lived experience member of the Expert Advisory Group. And what an excellent result the final report is. The final recommendations have the key enablers in their proper place, putting an all-of-government approach front and centre and leading the way. Then, an expanded future role for lived experience that is well defined. What a great result. Well done to all involved.
Thank you, Graham, for that contribution, and to Leilani. And I think the key message today that we need to remember as we continue this discussion is to really remember our own self-care. We are talking about things that may be distressing to people. We are talking about loss. We're talking about suicide. So as we go through the discussion today, please take some time to practice some self-care and to really look after yourselves during this presentation in the way that you know works best for you and at the conclusion. It's now my pleasure to introduce a message from the Honourable David Coleman, who is now the recently appointed Assistant Minister to the Prime Minister for Mental Health and Suicide Prevention. Both Minister Coleman and the Prime Minister wanted to be here today but send their apologies. Minister Coleman released this report last week at the Suicide Prevention Australia conference, and since his appointment has been a great champion of the work, and so we welcome a message from him today.
Well, good morning. It's great to join you all to discuss the final advice of Christine Morgan in her role as National Suicide Prevention Advisor. I want to begin by acknowledging all Australians with the lived experience of mental ill health and their loved ones. To those of you who work in suicide prevention, whether you're a psychologist, a psychiatrist, a GP, a nurse, a phone line operator, a lived experience worker, or any other role, the work you do is so important. Thank you. Christine's final advice is a significant body of work. It provides a roadmap for driving a major shift in suicide prevention in Australia. The crux of the report is that we need to find new ways to intervene earlier before a crisis escalates. We need to go to places where distress first manifests itself, workplaces, schools, within families and social networks, and out in the community. We must also be informed in everything that we do by the lived experiences of people who have been there. This is central to Christine's advice. In recent years, the government has taken important steps in suicide prevention policy, including establishing the National Suicide Prevention Trials and investing in aftercare services. And this report is another important step in our approach to suicide prevention. We will have more to say on this in the coming months, including at the budget. National Cabinet has asked for a national mental health and suicide prevention agreement between the Commonwealth and the States by November of this year. This agreement will pave the way for long-term reform. In 2019, 3,318 Australians died by suicide, 7 men and 2 women every day. It's estimated that each year a further 65,000 people will find their situation so unbearable that they attempt suicide. Many more will experience suicidal thoughts. This is the brutal truth, and it's why the next 12 months will be so critical. I want to thank you again for the important and very difficult work that you do every day. And I want to thank Christine for her final advice. I encourage you all to read it if you haven't already. And I very much look forward to working with you all in the months ahead.
Thank you to the Minister for his support in really getting this report out into the community for discussion by all our colleagues. It's now my great pleasure to introduce Dr. Jaylee Skean, OAM, who provided powerful guidance in her role as the Special Advisor to the Task Force over the last 18 months. And today she's being joined by Ingrid Ozoles from the Expert Advisory Group and Elle Gelock to really talk us through that whole of government approach and the compassion first model that has informed so much of the work today. So over to you, Jaylee, and the panel.
Thanks so much, Lucy. And I wanted just to say a bit of a thank you to Leilani and Graham for some of those acknowledgements up front. They're just two of the people we've had the opportunity to work closely with over the 18 months that the task force was working. And in this session, I'm also going to be joined by 2 others. I also wanted to, I guess, acknowledge up front in this particular part of the webinar, all of the people with lived or living experience of suicide who shared their experience, shared their knowledge, shared their pain, and indeed shared their hope for the future with us, because it was their voice and their experiences and their knowledge which really shaped and guided the interim and final advice reports. In fact, Compassion First, that we're going to talk a little bit about in this session, really drew together over 3,000 people's experiences, working in partnership with other researchers and lived experience researchers to pull together that data. And so none of this would be possible without all of their generous input and invitation that they took up to be part of this. And I think just in some early context, what I'd say is when Christine Morgan, in her role of the advisor, submitted the early advice in November 2019, what we talked through with the Expert Advisory Group was really the fundamental requirement for the interim and then final advice reports to be developed in 2020, that we had to fundamentally ensure that we could connect with and understand the lived experience of suicidal distress, of suicide attempt, and all other ways that people experience suicidal behaviour. To ensure that not only did the advice and recommendations connect with what people needed, but also connected in some way to what was required to kind of shift us forward in our approach. And so one of the things I'd say kind of early up in this session was, while many people had rightly already kind of flagged or indeed talked about the need for a whole of government approach to suicide prevention, what came through really strongly when we listened to and talked to and worked with people with lived and living experience of suicide is that in actual fact, we can't truly deliver what people need without that shift to a whole of government approach that is supported through whole of community and whole of life action. So I'm going to come back in a little while and talk to, I guess, some of the journeys and some of the kind of experiences that we connected through that report. But first, I wanted to hand over to Ingrid Ozoles, who was a valued member of the expert advisory group working alongside of us through this process, but also who many people would know as having someone who's really worked hard to bring both their lived experience and also all of their other skills and experience to the suicide prevention sector over many years. So I'm going to hand over to Ingrid to share some reflections.
Thank you, Jaylee, and thank you to all my colleagues and to the lived experience who participated in what is an amazing piece of work, one that I'm so proud to have been a part of. An essential part of this work has been and is to shine a light on the living experience of people who have survived suicide attempts, who deal with suicidal ideation, who are carers of people in such despairing pain, and those of us who are bereaved. And as one of several of the life experience members on this team, it's been an opportunity for us to come together and bring a flag of urgent need to these hidden and what has been often shamed stories. But we need to bring change, so we have to bring those stories to light. And that's what this piece of work has focused on. Suicide prevention is a human issue. It touches us all, or it will sadly, eventually in some way. So let's all be better informed and prepared to help prevention, to promote the how we can help, what you and I can do, so that we can get in early in any setting, and so that we don't have to reach crisis point to get the support we need. This work informed us about what truly matters and is needed at the devastating points that some of us may find ourselves. And the overwhelming responses that came through our work was that suicide is about unbearable pain, pain we want to stop, but pain we don't know how to stop. We want to be heard. We want to be listened to deeply. For the well-intentioned, let's park our biases. Let's not judge. Let's not belittle, berate, shame, add guilt, or try and fix anything, because that's not what we have to do. And that's what actually is harmful. We want to be acknowledged. We want our pain validated. By having someone sit and hold space with focused attention, compassion, and empathy, we can create a safe, supportive environment that connects us to another individual. The person in crisis, you and I, we are all humans, and we all want to feel valued, cared for, and that we matter. And at those critical points, that's exactly what people who shared with us their lived and living experiences was that they don't feel those things. Sharing these stories that have been far too little talked about and hidden needs to be researched. We need these stories and life experiences to open windows and doors for each other so that we can learn as a community how to be better educated, become skilled, enrich research, help develop and deliver more appropriate evidence-based, compassionate services, programs and interventions. At the end of the day, the intention of this work is to start giving Australians what we wished we could have received at our darkest and deepest disconnected points, so that we can create a stigma-free world where compassion really does come first when supporting vulnerable people. And that could be you and I, or someone we love or work with. Thank you to the team. I feel so proud at this, what is an emotional, pivotal moment, that we've been able to bring this difficult topic around talking about the lived experience from suicidal ideation to suicide attempts and bereavement in an open and honest dialogue. Thank you, and back to Jaylee.
Thanks so much, Ingrid. Really important and profound insights as always. So what I wanted to briefly do is really talk to, I guess, to some of the crux of the Compassion First report. And I guess it deliberately comes as the kind of first in the suite of 3 reports, because we saw that the lived experience was foundational to understanding what needed to shift and what were some of the enablers that were required to get that shift here in Australia. And so the report really draws on 10 different pieces of research, and as part of that, pulling together of the thousands and thousands of stories, we really wanted to summarise what were some of the common experiences that might precede a suicide attempt. And most of the focus of the report, while there was a chapter in the final report that looked at needs and experiences of caregivers and people bereaved by suicide, much of the focus of the report was really trying to understand people's lived experience of suicidal distress and of living through and recovering from a suicide attempt or many suicide attempts. And so what we were trying to do is capture some common experiences that might lead to some opportunities for earlier and more effective interventions and supports for people. But I would be mindful as we talk through just a couple of those journeys, just to reflect that no one single person's journey or the context of their life or the pain or distress that they feel would be exactly the same as somebody else. And so these were trying to capture some of the commonalities of experience. So within the 8 journeys that were kind of represented as part of the report, the first 3 of those came from a really large kind of survey data set of over 1,500 people led by the University of New England. And then we had some very specific journeys that were identified through specific consultations with young people, with Aboriginal and Torres Strait Islander people, with people from culturally and linguistically diverse backgrounds, from the LGBTIQ+ community, and also exploring the specific experiences of men. And so what I wanted to do was really just talk through the first 2 of those journeys, just really to give an example and not to be prescriptive, but to talk, I guess, through how some of the information, experiences that people shared helped us kind of identify some of the key opportunities, which have then kind of flowed through to the final advice recommendations. So the first journey that was identified through some of this research was really one that was shared by probably more than 50% of the people that were completing the survey, by thinking about their own words and experiences, that actually what had occurred for many people was some compounding experiences across the lifespan. And so what many people reported was some experiences early in childhood, some adverse experiences that had occurred for them. So whether that might be experiences of abuse or neglect in childhood, exposure to family violence, having a bereavement, including a suicide bereavement during childhood, and also some peer-based difficulties for people integrating into schools or peer-based networks as a child. Then people talked about some stresses which occurred while they were a young person in that youth space. And so often people talked about the first onset or first experience with mental ill health or with alcohol and other drug use. Many people also talked that at this time, many of the treatments or service supports were either ineffective for them, and so talked about those kind of early experiences as a young person. Also that some of the first experiences of self-harm or of a suicide attempt occurred during adolescence or early adulthood, and certainly some pressures to do with study, peer groups, and for young people who identify as LGBTIQ, those identity issues and experiences of discrimination and fitting in. And then experiences that occurred, I guess, co-occurring stresses that occurred in adulthood, often combined with a change in alcohol and other drug use as a way of trying to cope with those life stresses. And so some of the really common life stresses that people talked about close in time to a suicide attempt as an adult was a relationship breakdown, particularly for men, but for men and women, contact with the justice system, or first contact with the justice system or transitioning from justice system into the community, legal issues, including child custody issues or other legal issues, as well as experiences that people may have had with a suicide attempt or many suicide attempts in adulthood. That kind of is a bit of a summary of some of the experiences that people had across the lifespan. I guess the second most common journey that came through by looking at that kind of big data set was people talked about co-occurring stresses from different domains of life that all occurred within 1 to 5 years of each other. And so people didn't talk so much about compounding experiences across the lifespan, but really talked about different domains of stresses actually occurring pretty close in time. And so those first ones were around health and psychological stresses. So that might be for people experiences with mental illness or mental ill health, alcohol and other drug problems, or a change in alcohol and other drug use. But it might also include injury, pain, or the onset of physical or chronic health problems. So it could be in either the mental health or physical health realm. The second area of co-occurring stresses that people often talked about were related to unemployment, workers' compensation or workplace injury experiences, or other kinds of financial distress. And so people talked a lot about the impacts of financial and workplace stresses. And the third area really was talking about relationship stresses. So whether that's a relationship breakdown, being exposed to family-related conflict, or child custody issues. And so for many people, those three domains were often co-occurring. I guess the purpose of sharing just a couple of those examples and trying to, I guess, map some of those experiences in this way was to indicate the fundamental need to, one, act early in life or early in distress, to ensure that we go to where people are and that the supports that are provided to people are looking at not just the psychological and clinical supports that people might need, but actually being able to address some of the drivers of distress or some of the stresses that were impacting on people, which will not be the job of health services. And also ensuring that when people reach out for help, that support is provided at that point in which people reach out for help, regardless of whether that's through a health service, their workplace, a different government agency or service, and ensuring that that response was compassionate. That there were too many times when we listened to people's experiences that they talked about being turned away, that they talked about being judged or problematized, when what they were looking for was somebody to sit with them in their distress and to support them in a compassionate, person-centered way. And so what was clear from, I guess, some of this was the approach we required was really about understanding the context of a person's life, including the environments that they're in every single day, the services and supports they're interacting with all throughout their journey, and particularly in times of distress, but also ensuring that we understood a person in the context of their life and their community. So in sharing those two journeys, what I've done is talked, I guess, in more general terms, and we certainly don't have time today to tap into all, I guess, the targeted types of experiences and approaches that we might need to understand. But what we did want to do was, I guess, expose to one of the types of experience that shaped some of this report and some of the advice. And so what I wanted to do was introduce you to Elle Gallock, who is a member of the Youth Advisory Panel for Origin, and Elle was one of the people who participated in the consultation with young people specifically. And I think it's really important in everything that we hear from a diverse range of lived experience. And so I'm really pleased that Elle has given some of her time to share some of her thoughts and experiences with us today. So I'm going to pass over now to Elle.
Good morning, everyone. I think today is a really positive step in the right direction. From my personal experience, I am a long-term service user, so I've been in mental health services since I was 9 years old. I'm a carer for my mum. I've lost a friend to suicide, and I'm deeply linked with prevention because I see that every step of the way of my life, there have been opportunities for prevention, and whether it be financial constraints, situational constraints, social situation constraints, service access or appropriateness, it has been opportunities that have been missed. And I think it's really important to understand that in prevention, it is not just preventing something negative, it is uplifting someone in a positive way and a quality of life way. So I guess for me, the interviews were really positive, and I think it was a really wonderful experience to interact with the Commission and speak with other young people on the issue of suicide prevention and how it really does impact so many lives. And yeah, I think it's been really like that positivity in the actual interviews and the listening and the understanding, and how it sought out a positive approach with new questions, not just asking the same questions as previous. I think for me, what really needs to be done is designing services in a way that asks different questions more positively. Better centralised treatment and planning is essential, and that whole of government approach is really core to that idea. And I think a lot of young people will share experiences of dealing with multiple government agencies and dealing with multiple non-government agencies, and having the experience of bouncing between said agencies being the issue, and how the lack of communication, the lack of understanding and differential professionalism. And I think for me especially, it is those experiences of being bounced around or being forgotten that have been the parts of my life would have been like the lowest. And it's really that understanding that if people can get that positive treatment, their quality of life will be so much better. And suicide prevention is arguably quality of life improvement. And I think, yeah, we could really get a lot out of that. Because, for example, I'm trans, I've got ADHD, I've had all these mental health issues in the past. And it's been understanding that it's the society around me that needs to facilitate a quality of life improvement to actually, get better outcomes for myself and my friends. So yeah, I guess for me, positive policy really does mean for young people and means positive outcomes. So I think lots of services and government services really need to advocate for that positive social and economic policy that seeks to actually improve people's lives and has a real tangible impact on the endpoint logistics of service, because we always talk about the difficulties of services being overwhelmed, and quite often that's a big driver for people's distress is accessing services and then being pushed away or turned back, and it can feel almost hopeless to even access a service. And I think that's really important because it's all about hope, and if you do not see a future, you don't see hope. And yeah, I think it's really important that we, summarize these findings in such a way that for you can take home that these findings are positive, they involve young people in a really positive way, and that this is about quality of life and how we can adequately, find people's journeys and use those journeys in such a way that will improve lives down the track and their own lives within themselves. So yeah, I think that's all I'll say. Pass over to Jaelia. Sorry.
Thanks, Elle. I really appreciate that. And I think a couple of really great things that you mentioned, and I know Ingrid says this all the time as well, which is people's experience of suicidal distress and suicide are not unidimensional, that many people who've experienced suicidal distress themselves are also caregivers or been bereaved by suicide, and actually many people work in the suicide prevention sector and space. And so that was a great reminder of that, and also the sense that while people were often sharing quite distressing experiences of where things hadn't worked as well as they could have, what actually came through a lot of the work was a sense of hope for the future and a sense of wanting to be part of positive change. And if I could say, just as a final kind of personal reflection from me, what a privilege it was for 18 months to be stepping outside of my usual role and into the special advisor role, because actually what I was forced to do was to listen deeply and to put some of my own personal views and expectations aside and ensure that the voice of multiple people, including and centrally people with lived experience, were able to come through in the final advice. And that doesn't mean that one type of experience is more important than anybody else's, but it's actually our shared collective knowledge, experience, and hope for the future that's actually going to create opportunity for change. So I guess what I wanted to just summarise is to say that in the Compassion First report, there was a number of opportunities for change which were reflected. There was 10 of them. And what you'll actually see is that many of those opportunities for change align and support the final recommendations in the advice and some of the priority actions. They also set the foundation for the shared understanding of suicidal behaviour that is critical as part of the Shifting Focus document that Alan will speak to later. And so what I'd like to do now is hand over to a pre-prepared video from Professor Pat Mcgorry, who's going to reflect on some of the current need before Lucy Brogden will be back to introduce Christine Morgan, who'll take us through the recommendations. Thank you.
Hello, everyone. My name is Patrick Mcgorry. I'm the Executive Director of Origin, and I really appreciate the opportunity to talk to you today about the prospects for suicide prevention. It is a relief that the very high suicide rate has not deteriorated further in the context of the pandemic, and the reasons for this would be good to understand. But I think it's very important we don't become complacent. We saw a rise just prior to the pandemic from 8 to 9 suicides a day, and the situation, particularly for young people, is actually getting worse. So we need to redouble our efforts. How do we do this? Well, I think Christine Morgan's plan covers all the bases extremely well, and it rises above the false dichotomy which often we see in this space, where people talk about social determinants and upstream efforts to intervene early as somehow in tension or competition with providing crisis and acute care to people. Of course, we need a spectrum of activity, and the reason the crisis and the acute care issue is so prominent is because of the underinvestment in upstream missing middle activities to intervene prior to the really acute and highly dangerous suicidal crisis. So we need to invest in all of these activities and basically implement every single level, because no one thing on its own is going to turn back the tide. But the low-hanging fruit certainly would be to help much more effectively the people who are reaching out for help and being turned away on a daily basis. And we have seen a surge in the pandemic of suicidal behaviour, even though that has not yet resulted in an increased death toll. So look forward to hearing other people's views, and thanks for the opportunity to speak to you today.
Thanks to Pat for those comments today. And I think Pat's comments and the earlier comments from Ingrid and Jaylee and Elle really highlight that full spectrum of work that's been undertaken to develop that shared understanding that comes from right upstream prevention to the need for good crisis and clinical support, if that's what's required at that time. And so that shared understanding has been really shaped into a very connected set of recommendations underpinned by the need for compassionate care. And to talk us through that, I'm pleased to introduce Christine Morgan, wearing the hat as the National Suicide Prevention Advisor, and to take this quick opportunity to congratulate her for this piece of work and leadership. Not only was Christine undertaking this work last year or for the past 2 years nearly, but she kept her day job as the CEO of the National Mental Health Commission, and on top of that was really instrumental in providing great advice to government during the COVID pandemic. So it was almost 3 jobs in one for much of last year. And so thank you to Christine on behalf of all of us here today. We've got over 300 people online deeply interested in this topic. And so I'll allow Christine to take us through those 8 key recommendations and then the immediate priorities and how that's going to all take shape. So over to you, Christine.
Thank you, Lucy. Good morning, good afternoon, depending upon where everybody is at the moment. And thank you for the opportunity of connecting today. Before I start, I would like to acknowledge the traditional custodians of the various lands upon which we are all meeting. Here in Sydney, it is the Ngunnawal people the Gadigal people. That shows how frequently I'm in Canberra. It's the Gadigal people that I'm with today here in Sydney of the Eora Nation. I also want to acknowledge all those individuals and families who have been impacted by the lived experience of suicide. And I thank in particular today all those who have joined as voices of lived experience. As you will consistently hear from all of us who have been involved in this work, lived experience has been absolutely foundational to informing not only what we've done, but how we've done it. My task today is to unpack the recommendations and to explain why we have chosen each of those recommendations and how they could and should be put into effect. Before I do so, it would be totally remiss of me to not actually broaden this away from being the advice of the National Suicide Prevention Advisor, to actually say it's the advice of a collective effort of expertise and wisdom. I am but a conduit through which this is being presented to government. So firstly, thank you, Jaylee. Jaylee, without your assistance, without your inspiration, without your absolutely pivotal work, we would not be where we are today. Thank you on behalf of all of us. Thank you from Jaylee and I to each member of the Expert Advisory Group. Lucy, you and Alan as Deputy Chair have steered us through some very real challenges over the last 18 months as we've really tried to grapple with what we've done. I would like to take just a minute to acknowledge the input, though, of each and every person who was on our Expert Advisory Group for the full period of time that we met. To Nikki Barth, Stephanie Caminiti, Co-Joint Professor Gregory Carter, Professor Helen Christensen, Leilani Darwin, Professor Pat Dudgeon, Parker Forbes, Graham Holdsworth, Professor Myth Maple, Pino Migliorino, Nevis Murray, Ingrid Ozoles, Professor Jane Purkis, Glenn Poole, Professor Nicholas Proctor, Associate Professor Joe Robinson, and Professor Marie Thiessen. None of this couldn't have been achieved without your expertise, your experience, your enthusiasm, and your preparedness to commit your time and efforts. As I've already mentioned, but I will say it yet again, each experience from the lived experience and living experience has contributed to us. Without your voices, we would not be here. Thank you. I also acknowledge the opportunity and the support of the Prime Minister and Ministers Hunt and Coleman in bringing us to where we are today. So let's turn to this. Firstly, a very brief background as to just remind us of the journey, I guess, over the last 18 months, and then a deeper dive into the recommendations. So we've heard again and again, this has been shaped by lived experience. If we go back to the opportunity we were presented with in 2019, we were called upon to do some initial findings at the end of that year. And those initial findings said to us that there was very much a paradigm shift that was needed. That paradigm shift needed to take us to a place where we had an outreach approach to reach people in distress. We needed, perhaps I could just ask if we can go back away from the recommendations at this point. I'll get to those in a moment, but could we just go back to that previous slide? Thank you. Because I think what I don't want to do is by focusing in immediately on those priorities and those actions, distract from what it was, the journey, because the journey was really important. So we said we needed to have a paradigm shift. That paradigm shift needed to take us into an active outreach approach. We needed to reach people in distress. We needed to be much more substantive in how we involve lived experience, as we've heard consistently, to stop using lived experience to illustrate points that experts wanted to make and really allow lived experience to go to the heart of what we were doing. And we had to address the significant disconnection in our service provision. That shaped our work in 2020. But as we went into 2020, Jaylee and I actually stopped, and with the support of the Expert Advisory Group, we said, look, the assumption's been made that we need a whole of government approach. Is that or is that not true? And that led us immediately into the work that we've heard today outlined as being compassion first. We really had to interrogate that question. And we had to interrogate it through the reality of people who'd been to the point of suicidal distress, people we could actually talk to, because that was one of the other things we discovered in making those initial findings, that we talked about suicide deaths, but we didn't engage with those who had actually been to the point of crisis. As we've heard compellingly from Jaylee and others today, we were left with a point of where we couldn't go back from it. If you accept what people are saying to us, which is that the journey into suicidal crisis and attempt begins in advance of that, you must go to whole of government. So our landing point became very much, yes, we need a whole of government approach, and no, we don't need to take away from the work that Pat has so strongly recommended we continue with, that crisis intervention, but we did have to balance it out with targeted distress intervention. Call it the two arms of the coat hanger. Do not take the pedal off those services that are needed for people who are in crisis, for those who have attempted, or those who are supporting those who have lost people to suicide. But introduce and balance out with targeted interventions that will meet people in their distress. So let me now take you through what each of those recommendations will be. There are 4, and thank you, if we can go to the next slide now, thank you. As Graham mentioned, there are 4 enablers and 4 key shifts. The enablers look to what are those nerve points in the system that we actually have to change. So what we've tried to do with these 8 recommendations is to actually come up with 8 recommendations that in and of themselves will stand the test of time until that part of the system has actually been changed. And looking at them in their entirety, that system change cannot and will not be achieved if any one of those is not pursued. I will take you through priority actions, which come in under each of those recommendations as we go through the next slides. But those priority actions are but starting points. Each and every one of these recommendations in and of themselves are critical to ensuring that we actually achieve that paradigm shift. And we land in a spot where we have got outreach to people, where we are meeting them in their distress, where we are enabled to do so, and where we're doing it in a way which will connect them compassionately to the services they need to end up where Elle herself has eloquently put us, an improvement in quality of life. The enablers go to what are the leadership and governance structures we need? How do we actually do this thing called embedding lived experience around our data and evidence and our workforce capability? And then the shifts that we need, shifting to that response to earlier in distress, shift to being able to connect people to services they need and supports they need, where they don't have to try and find them themselves. How we address those groups in our population that are disproportionately impacted by suicide, and we heard that so strongly through Compassion First. And then what about some policy responses to improve our security and safety, so maybe we don't end up there in the first place? So let's unbundle each of them. Firstly, the first one, which is to enable leadership and governance. I'll take the time as you read the slide to actually articulate or to actually talk to or read out the recommendation in and of itself, and then I'll try and unbundle a little bit. So the first one, all governments, by that we mean all governments, Commonwealth, state, territory, but also down to local government. All governments work together to deliver a whole of government approach at the national, cross-jurisdictional, jurisdictional, cross-portfolio and regional levels, with national outcomes to be developed and adopted by all governments. So picking that out in criticality, we've got to have here a national approach where all of our levels of government come together to say, what are those touch points where we have to have consistency, where we have to have scalability, where we've actually got to have input that achieves things on a national basis. Then recognising that within each jurisdiction, whether that's the Commonwealth jurisdiction or a state or territory, we actually need to make sure that all of the portfolios available to that government are being used. And then most importantly, how do we actually try and ensure a consistent regional application? And I will own here the fact that I don't think at the moment we've actually aced that last one. I think we know pretty well what we could and should be doing nationally. We kind of know, though we haven't yet done it, what we need to do in the cross-portfolio space, but we're still actively exploring the regional space. The final bit that we put into this recommendation, and it was very intentional, was that national outcomes not only be developed, but be adopted by all governments, because until we move to an outcomes approach of measuring outcomes, we will just be measuring activity. Now, the 4 things that we think could immediately be done, we identified these in a very proactive 2020-2021 scenario, were these. And this comes about after consulting broadly across all jurisdictions. Firstly, get First Ministers to authorise it. We absolutely know that unless a First Minister is requiring this to be done across all touch points of government, then at the best it will be a Health Minister encouraging colleagues to contribute. We must have authorisation by First Ministers. Secondly, we need a national suicide prevention strategy. Now, this does not in any way take away from the excellent strategies and works and plans that are there already, but a national suicide prevention strategy, and it won't be sort of war and peace. It will be what are those things I've mentioned that due to scalability, due to reach, due to the need for consistency, must be done at a national level. Because if they're not done at a national level, then it will impair the effectiveness of the whole system. We strongly recommend what Suicide Prevention Australia and others have been talking about for a long time, which is the establishment of a National Suicide Prevention Office that could and should be done in 2021. And then finally, as Minister Coleman talked about the fact that there'll be a national partnership agreement for mental health and suicide prevention, we absolutely call for there to be a focus in on what do we need to do at a regional level. Secondly, the second recommendation is all governments commit to integrate lived experience knowledge into national priority setting, planning, design and delivery, and evaluation of suicide prevention services and programs. The key verb here is to integrate, not to use, but to integrate. And in order to fully integrate, to embed it, that needs to be in those 3 key areas of government. That place where you, at a national level, set priorities. That point where you actually do your planning, designing and delivery of services, and those areas where you do evaluation of service. Lived experience needs to be embedded, not used, or not just used. 4 key priority actions which can be taken straight away is bring that lived experience straight into your leadership and governance structures. Don't just use it in an ancillary way. Don't just use it for consultation. Bring the diversity of lived experience right there into where the decisions are made and through the structures where decisions are implemented, which is your leadership and governance. Secondly, very practically, as a government entity with money that you give out to organisations and service providers and to researchers, please can you make it a gateway issue that you don't actually get that contract unless you can demonstrate that you have experience of engagement and co-design with lived experience people. Otherwise, just you don't get the funding. It has to be that embedded. Thirdly, a no-brainer. Make sure we've got adequate funding and resources to build a lived experience workforce, including our peer workers. And fourthly, and we couldn't not have this one after all of the work and the findings that came out from Compassion First, please increase lived experience research, but ensure, please, that we continue to focus on the reality of those who've been through suicidal distress or crisis. Thirdly, recognising that measurement of outcomes is essential to monitoring impacts of suicide prevention initiatives. All governments commit to work together to identify data needed for such measurement, undertake to improve the quality and timeliness of that data, and enable sharing across agencies. Now, it would be fair to say that many of us can contribute, particularly from our research expertise, what type of data we need to measure outcomes. And that, I think, is important. But we actually need that commitment from governments to be engaged in that process. We also need them to do the very practical things that could and should be done to ensure that we improve the quality and the timeliness of the data, and things that only governments can do. And if they don't do this, then we can talk about it as much as we want, it won't get done. They actually have the policy and legislative touch points to enable sharing of data, and that is absolutely critical. For immediate things that could and should be done, around our suicide registers, keep them going, and where we still have to implement them, accelerate that action and ensure that we are collecting information, not just around deaths, but also around suicide attempts and self-harm. Secondly, let's have regular national surveys that go to the heart of population prevalence when it comes to ideation, to self-harm, to attempts. And let's include and focus on our priority populations. Thirdly, we must develop and implement a national outcomes framework, and we must have a national definition and standards for suicide attempts and self-harm. Until we do, we won't really be able to get a picture, not only on how we can prevent losing people to suicide death, but most importantly, how we can intervene effectively and ensure that people don't end up in suicidal crisis and attempt. And fourthly, we need to have national priorities for research, but also for how we translate that into effect. Those last ones, the 3 and 4, are things that we would recommend be taken up by the National Suicide Prevention Office if it's established. Recommendation 4, all governments to commit to prioritising evidence-based and compassion-focused workforce development, to drive cultural change, and to improve the capacity and capability of all workforce involved in suicide prevention. So this is one where, as soon as you get to a whole of government approach, you actually must look at what is the workforce development need across the spectrum for each of those touch points with people who may be at risk of suicide or are going through a journey towards suicide. We must actually ensure that the type of training and workforce development truly does drive cultural change. The compelling voices in Compassion First said, we don't want to be problematized. We don't want to be medicalized. We want compassionate approaches. We heard that from Ingrid and from the others. So that does actually require cultural change. So our workforce development initiatives need to actually acknowledge they've got to drive that cultural change, as well as increasing capacity and capability. So coming across into immediate actions, let's first deal with our clinical and health staff, because if we can't get it right in our health service settings, then boy, we still have a long way to go. So we need to ensure that across our clinical and health services, that anyone there has received contemporary evidence-based training around identifying and addressing suicide ideation, behaviours and risks. Then let's extend it to our frontline workers, and let's here provide them with contemporary compassion-based training, where in real time they can help to be able to identify distress and know how to manage it. And we've gone a step further and said, okay, in 2020, 2021, what are we seeing as being particularly important frontline workers? And those 3 areas where I think if you made a start on this, it would be a damn good start, would be those providing support around finances, employment, and relationships. And then thirdly, we need a specific workforce strategy around suicide prevention. So there are 4 enablers. Then we go to the 5th. The 5th is the beginning of our key shifts. As a priority action and reform, all governments work together to develop and implement responses that provide outreach and support at the point of distress to reduce the onset of suicidal behaviour. This one we really need to get out there. We need to acknowledge that this is an area of reform, not just of action. This is new work. We actually need approaches in this early distress which are outreaching to people, anticipating their needs, not waiting for them to come to us. And the outcome we're looking for here is to reduce the onset of suicidal behaviour. Very specific. The immediate actions we can do here. The first one we must do is to look at early in life. How do we actually mitigate adverse childhood experiences, how do we better support families, and how do we ensure that any child or young person needing it has got early, timely access to treatment and support. Secondly, scalable early distress interventions. All jurisdictions can get involved in these. Again, we've gone to the point of saying, what is the reality in 2021 as we come out of COVID? What are those real nerve points that we're experiencing at the moment? What is the data telling us? And early distress interventions in 4 key areas would make a significant difference for those coming out of the pandemic. Those going through intimate relationship distress, employment or workplace distress, financial distress, and a very key one that came out of last year, isolation and loneliness. Then we also need to look at what can we do for people coming out of transitions. I think it's well understood that people leaving the military, that has received a lot of publicity. We need to look at what we can do there. But others that are really important, for those entering or leaving justice settings, they have a significantly increased risk of suicide. Those disengaging from education and vocational settings. And let's not forget our older Australians, those entering retirement or those for the first time engaging with aged or supported care services. So that's our early distress. The second one in a key shift is actually about what we can do within our health settings. So if we can go to recommendation 6, and this is specifically around our health settings. All governments work together to progress service reform to achieve integrated, connected and quality services for people firstly experiencing suicidal distress, for people who've attempted suicide, and for caregivers and people impacted by suicidal behaviour. Now, there are 2 plans, strategies, whatever you want to call them at the moment, which actually have been signed up to by all 9 jurisdictions, the Commonwealth and each state and territory. They're active, they're alive, and they have embedded in them priority actions which could further what we're doing in terms of service provision within our health sector and more broadly around suicide prevention. And that is the National Suicide Prevention Strategy, which has been developed under the 5th plan, which is specifically around a health response. And the second is the National Mental Health and Wellbeing Pandemic Response Plan. All 9 jurisdictions have signed up to these. If we did nothing more in those than take some of those priority actions, we would progress in this area. So what are some of those 5 that are stated? Integrate digital and face-to-face services, make sure there's increased connectivity. Secondly, in terms of new flexible service models that are coming forward, make sure that they're community-based, make sure they provide compassionate support for people in suicidal distress. Aftercare, absolutely, but expand it please, not just for those who have attempted and who've been identified in the hospital systems, but for anybody who's had an attempt or anybody who's been in crisis. Support for families, for caregivers, for those who are bereaved, post-vention and bereavement services, and connecting in with our alcohol and other drug services. So let's improve our health response. Then the second last one, which is recommendation 7, is targeting groups disproportionately affected. And here what we call for is that all governments apply an equity approach to suicide prevention, to both planning and to funding, to prioritise targeted approaches for populations disproportionately impacted by suicide. When it comes to what we can effectively do for our priority population groups, it's not about a population allocation of funding and resources, it's about an equity approach. How can we ensure that those population groups' needs are identified and met? Key priority actions. Firstly, a national Aboriginal and Torres Strait Islander suicide prevention strategy must be implemented, not negotiable. Secondly, we need to look at what we can do to prioritise access for males. Not so much about male-specific services, but actually males should be able to access any suicide prevention or suicide distress service that we are providing. What are some of the things we can do? We can look at government leverage points where they intersect with employment services. The family law courts, we've heard so frequently now that that is a point of real distress. Relationship services and aged care. And we can require and should require all jurisdictions to review their current services and to specifically report on how accessible or not are they for males. Thirdly, we need to look at specific actions we can do for priority populations, and we call them out. Our children and young people, our LGBTIQ+ communities, our culturally and linguistically diverse communities, veterans and their families, and rural and remote communities adversely impacted. And fourthly, let's not forget this, there are certain occupations and industries where there is a significant risk of suicide. Veterinarians, one of the highest risk areas for suicide. And then finally, and I know I'm going through these quickly, but unfortunately time dictates that. So the final and 8th recommendation is working towards a quote unquote suicide prevention in all policies unquote approach. All governments build capabilities within their key policy teams and within their departments to actually understand those policy touch points, and that they then review existing policies to enhance opportunities for improved security and enhanced safety. This is really talking about a blue sky approach where we actually say, what are we doing in our e-safety places? What are we doing in our social structure places? How are we improving safety and security for all Australians? So in conclusion, we now know, I think, we know that there is a not negotiable approach to whole of government. And indeed, as our Prime Minister said at the National Federation Reform Committee at the end of last year, actually he said, I think what you're talking about is a whole of governments approach. Yes, it does need to be whole of governments. This advice, these recommendations based upon those powerful voices of lived experience takes us to the point where let's just stop that conversation. We know it needs to be done. These 8 recommendations go to the nub of what is it that we need to do in order to ensure that that change, that paradigm shift has been achieved. So look, I will stop there and pass back through to you, Lucy, for Alan to take us through a practicality of how to do it, and happy at any time to explain any of these recommendations in further detail. Thank you.
Thank you, Christine. It's might be 8 recommendations and lots of strategies, but there's an awful lot of work in there. And I hope that many people on the line, the nearly 300 people, will see their voice in these recommendations, because they've really come from our community in all aspects of the community to shape the advice to government. It's now my pleasure to introduce you to Alan Woodward, my fellow commissioner and deputy chair of the Suicide Prevention Expert Advisory Group, and Stephanie Caminiti, who was a member of the advisory group, to really go through the next stage in that shift the focus and how we go about doing this and achieving those recommendations. So over to you, Alan and Steph.
Thank you, Lucy, for that introduction. And Steph and I will be brief, so we still have some time for questions, just to assure everybody. The companion document that's titled Shifting the Focus is a way of translating the recommendations, the approach, the insights to the prevention of suicide and the outreach to people in distress that's been gained through our work, to translate that into ways that can be applied, particularly by government agencies and portfolios and services, but also for those in the community and the wider society, businesses, workplaces, organisations providing suicide prevention services. So it's intended to be a useful tool, to be a resource that guides people in how they can identify how to contribute to suicide prevention. If I could go to the first slide. So a shared understanding is a critical part of working together. And looking back, as we started to work through the expert advisory group and listen to the voices of experiences, one of the things we recognised in this was there are different understandings of suicide, and they can sometimes be barriers to collaboration or coordinated effort. So it was important that we put forward a shared understanding and put it clearly for those who would then be looking at what their contribution might be. It also is important that the shared understanding be a contemporary understanding of suicide and suicidal behaviour. that it is based on what is known now, what has emerged through people's experiences of suicide, of bereavement by suicide, of caring for others, and also through the research evidence and theory base that is emerging and strengthening nationally and internationally. It is also important that the shared understanding be an informed basis for action using data and continually appraising those people and groups in our community that have particular vulnerabilities, those who we need to give particular attention to, and of course, how things are working. So we continue to improve what works well rather than continue to do things that are less effective. And thirdly, the shared understanding, at the risk of repeating the message so often mentioned today, the shared understanding must have at its heart a compassionate response to people in pain and distress. And just to reinforce a quote from the Shifting the Focus document from a person with lived experience of suicide, helpful responses are those that see our humanity, offer time and a safe space to be deeply listened to and validated, provide genuine compassion free of judgment and agendas. This empowers a person to find their own meaning and the answers to the problems in their own life. So is a values-based, an attitude-based, if you like, almost an ethical basis for the shared understanding that is underpinned by humanitarian, compassionate responses to people. Next slide, please. The document identifies 4 elements of a comprehensive approach. Firstly, it addresses policy and strategic actions by governments. It particularly addresses social and economic drivers of distress, but also makes the point that the intersection of those with health broadly and with mental health particularly are also relevant, so that we see that there is a need for policy action and sometimes deliberate program and strategic action by governments at all levels as part of their contribution. Secondly, that cross-agency programs and linkages need to be formed and strengthened. Typically, agencies such as housing, income support and financial support, family support, education, including schools, justice portfolios, also contribute to suicide prevention, as does the health portfolio. And we've seen through the lived experience stories how these factors might combine and create trajectories, which, if we're able to make the offer of assistance earlier through outreach across various aspects of government, we may be able to alter. Furthermore, action towards the protective factors, or to use the words that Mcgorry mentioned, the more upstream action, so that we avert a trajectory in crisis from occurring much earlier on. These linkages need to be formed and manifested in different program and service models. Thirdly, the use of available touch points to provide outreach early when a person presents with distress, recognising that governments, through the array of services and contact points they have with the population as a whole, are likely to come into people at times of distress. This can be planned for and known, and therefore a capability and a standardised response to people in distress can be adopted across a whole array of government services, knowing that that will have an impact in the prevention of suicide and, of course, the provision of compassionate support for people in their times of need. And fourthly, there, a coordinated and responsive system of care, emphasising, as is in the recommendations, that coordination occur at the most local level possible, meeting people where they are and working across the levels of government as well as across the different portfolios and agencies so that the person is not left trying to navigate a difficult and complicated system, but rather is guided and assisted in doing so. Next slide, please. The Shifting the Focus document also contains 3 references to enablers: the workforce capacity building, the establishment of governance and oversight and reporting, and the use of data and evaluation systems for continuous improvement. Next slide, please. Oh, sorry, I've gone too far. Back to, can we go back to the first slide, the composite slide? Thank you. So this diagram shows that the shared understanding, the comprehensive approach, and the enablers are then translated in a very practical form with a decision-making tool. The idea is that those in government agencies, those in community organisations, those in workplaces at all levels might use a decision-making tool to create their own suicide prevention plans and build their opportunities and capabilities to contribute to the prevention of suicide. One other quote I would like to refer to that's contained in the Shifting the Focus document, coming from the Voices from the Yarnum. The solution lies not only in what will help people stay alive, but also in what will enable all people, regardless of disadvantage or disability, to want to live. Again, emphasising that there are protective and positive factors that can be taken, as well as responding to identified issues of risk. I'd now like to involve my colleague on the expert advisory group, Stephanie Caminiti, to speak with us. And I wanted to ask Steph particularly to make a comment of what difference she thinks the shared understanding and the common approach might make in the lives of people who experience suicidal thoughts. Steph.
Thank you, Alan. I think it will be critical in gaining trust within people who are experiencing suicidality or caring for someone or have lost someone to suicide. I think the common occurrence that I have when I'm speaking to people of the community and myself when I was going through my personal journey is lack of trust with clinicians and government agencies, and it often seeming like it was just a tick box action. So to refer to pretty much what we've been saying the whole time today is lived experience being embedded and not just a tick box will make a huge difference in gaining the trust, in people being able to help seek. They'll be more likely to help seek, and it will also give people hope to see that agencies, people in professional jobs or things that seem unattainable are actually attainable. Even though we have a mental health struggle, mental health issue, we'll still be able to be productive and live fulfilling lives once we get the help that we need. And most importantly, it be accessible to everyone, every member of the community, not just based if you've got money to go privately or not. It's based on everyone is and should have the right to this quality care, and it will be really gaining the trust of the community, I think, will be critical, and this document will help do that.
Thank you, Steph. And yes, trustful services that make a measurable difference in the quality of people's life that address their issues. Back to you, Lucy.
Thank you, Alan, and thank you, Steph. And well done to everybody. You've landed us with some good amount of time for questions. We've just got a slide up there with support services while people are putting more questions into the Q&A. And please don't think me rude for looking up and down, but I've got to try and juggle the question screen and the viewing screen at the same time. And while I've had a lot of practice over the last 12 months at this, it's never a good look on screen to see someone looking very distracted, but I'm not. In terms of the questions, we've really got Christine, Jaylee, Alan and Ingrid, but everybody online has said that on our panel today is happy to take questions that are directed to them. And Christine, I might just start with some questions that have come through and put a theme to them for you in terms of the next steps. We know that the budget's on the 11th and the government's given some indications to sort of look out that there'll be some response in the budget, but people are just interested in that next step phase around what the government's position is and their next steps. If you could talk to some of that for the audience, please.
I will do, Lucy, thank you. So look, let me put an upfront caveat to this, that I'm not in a position to be able to know what it is that the government will be responding in the May budget. So from that perspective, I can't give any insights into that. I do know that the commitment has been made, and we've heard that again from Minister Coleman this morning. So there will be a response is what I'm anticipating. Now, how far that response goes, we don't know. But I think if we pin all our hopes just on the government response, we're going to fall at the first hurdle. I think the real power and the real momentum that has been provided to us through this combined advice and the work of so many people is we actually do know what needs to be done. So my intention, Lucy, and I think that all of us will work with this, I'm going to be calling on you and Alan and everybody else to do this with it as well, is that there will be some form of response. We will link that response in with these recommendations. We'll link that response in with what we see as the priority actions. And then we'll just start collectively to use all of our touch points to take it forward. As I say, I think one of the most powerful things we have is we do actually have our pandemic mental health and wellbeing response plan, which is a live document that goes into the future. We have all 9 of our health focused jurisdictional responses saying we know the priority actions. And we, I think, through the last 18 months, 2 years, have built an even stronger collaborative network with all of us to take it forward. So yes, we need government, and we will never take our foot off the pedal of arguing to government for what we need, but we can also do things ourselves. So short answer to this is I can't know what the government will do, but they've said they will respond. That has to take us forward in some way. And from there, we build our roadway and we keep walking down it, because we're in a position where we can't not do it now, Lucy. We know what we need to do, so we will get on and do it.
Thanks, Christine. And I think this question really is for all of you to have some commentary around. We've got a few questions in there around the workforce development question, themes around what does that compassionate care training, what that might look like. How might we embed it in pre-service training for our health and allied health sector? And I think these are really interesting, and even the opportunity for family members and those that love and care for someone living with suicidal ideation, how they might skill up. So I put it to you.
Lucy, I might on that one throw it to Jaylee, because
Sure.
This was something that we looked at in a lot of depth, actually, with the interdepartmental committee. Sorry, I have to go back into bureaucracy land, Jaylee, don't I? Not into community. And the interdepartmental committee had some high-level government representatives on it to look at these workforce issues, and it was one area they focused on. So, Jaylee, could you perhaps take that question?
Yeah, and it's a good question. I think one of the fundamental things we need to identify, actually, who is the workforce in suicide prevention or in early distress responses, that sometimes people think about the suicide prevention sector as being the clinical service providers, and while they are critical in suicide prevention, we have got a lived experience and peer workforce which is emerging and blossoming and critical. We have got touch points in every government agency and department who interact with Australians at certain times of distress or under kind of pressure or change or uncertainty. And we've got lots of different opportunities in community networks and others. And so I think what we really need to think about, and I'm a bit of a passionate person about workforce development, is I think actually that's why a workforce strategy was recommended, because what we need to ensure that our clinicians, many of the states and territories have kind of picked up the need to do this. It's in the suicide prevention strategy under the 5th plan, is we need to ensure that our clinicians are getting contemporary and quality evidence-based suicide prevention programs. There are a number of them. We need routine kind of rollout, but it's not just about training, it's about mentoring and support and the environment in which our clinicians are working. But we must broaden out and we must be thinking about all of those services that have a touch point with people in the community, and also investing in that kind of early development of those professionals in their pre-service training when they enter the workforce, as they change roles, as things shift and change.
I'd like to put a notion as well. As one of the many hats that I wear, I'm really proud to be working with Suicide Prevention Australia, and we're currently doing a fantastic piece of work looking at developing and having started to develop a competency suicide prevention training framework of standards for the non-clinical workforce. And it's a sector-led piece of work that's progressing. And one of the major things that has come out in the many consultations that we have been doing is the need for compassion. And one of our values that keeps coming out is having a value around compassion. And that's brought about some really interesting conversations around, is compassion something we can learn, or is it something that's innate? And we've now found through our own literature reviews that compassion can actually be measured. And so in our framework, we're actually looking at our communication skills. How can our communication skills help to build compassion? Words matter. Language matters. Some of those are really important starting points to start to help the community in whatever work role they play in actually helping us to think, well, okay, we need to think about how we communicate to each other. What language is helpful, what is unhelpful. And so we're certainly looking at how can we provide appropriate training that helps to build up, enhance capability and capacity, not only in the non-clinical workforce, which we're defining as lived experience and peer support, as well as other non-clinical workforce members such as industry, all sectors, hairdressers, tradies, OH&S managers, and also hopefully that this will extend to our clinical workforce, because as we know, we still don't have enough qualified workforce members in suicide prevention training. So that's a piece of work that's happening right now, and hopefully we'll be able to share it with you on a wider level and a public level towards the end of June. Thank you.
Thanks, Ingrid. Any of my other colleagues want to add to that? I think it's a really key question, and it's something that will be a work in progress, but I think these are some of the recommendations that the sector can start working on themselves, and that's what's quite empowering in this report. Another question and a theme has come through in terms of issues around data, which is, you know, a big topic in this sector, and particularly when we get to this high level of policy design, but it also impacts significantly on service design. And so the questions are around capacity, particularly around the recognition of gender identities into data collection services, etc. And we've come a long way, but there's more work to do. So just wondering if Alan, Christine, Jaylee particularly might want to talk around the data gathering mechanisms and really the significant developments we've seen and the work that's still to be done when it comes to data.
I think on that one, Lucy, perhaps Alan, you could talk to that, because I think a lot of work is being driven through the Suicide and Self-Harm Monitoring Project and the work of the AIHW and others. So, Lucy, perhaps Alan could speak to that.
Sure.
Okay, my pleasure. And I think many people, but maybe not all, are aware that the Australian Institute of Health and Welfare has now established a suicide prevention or suicide data coordination project. And there is, as part of the AIHW website, the collection of the suicide-related data. most of the data collected has in the past and still remains around those who have died by suicide. And presently the AIHW data portal does largely contain that data, although with many additions in terms of linkages to other data sets that greatly enhance our ability to look at the profile of those who have died by suicide, and also to look over time and geographic and other trends. The challenge ahead is around data relating to suicidal behaviours and underlying levels of suicidality in the population. And pleasingly, there is work underway across all jurisdictions in Australia to look at that. It's not necessarily easy, but there have been data sets obtained, for example, through the use of ambulance operational data that is now starting to come forward. And there will be further developments as we start to look at other data sources. The recommendation in this report we're discussing today around common definitions of suicidal behaviour is a very important component of improving those data sets. And another initiative that the government has shown commitment to is conducting national mental health and wellbeing surveys, as was done back in 2007, which collect population level data around underlying suicidality and distress levels. So we're on a journey where we're actually greatly improving the data, and through the AIHW portal, the accessibility that people have to that data. And, you know, part of the implication which you see in the tool that's part of Shifting the Focus document is that people use that data for planning. They look at how their own data sets from their own services and activities can also be used to inform their improvement and check their reach and their effectiveness. And ultimately, we would like to see data that relates to a standardised set of outcomes for programs and services in suicide prevention. So there's a lot still to be done, but we are well advanced on this journey.
Thanks, Alan. And I'm mindful that we are now at 12:31. We've extended the Zoom a little bit longer if people can stay online, but we will be undertaking to answer the questions. And there are still 35 questions in the chat, although some of them do have a common theme. But I guess just if I can put a final question to you, Christine, as the special advisor. It's a common theme, and Elle, you've really stolen the show today, but how do we gather those great voices that we've really been working with for the last 18 months to shape this input, whether they've come through Origin and Headspace and, you know, the great work of Leilani in connecting to people of lived experience right across Australia. How do we harness that energy to continue to shape both good policy design, good service design to really bring that lifted outcome?
Big question. Thanks, Lucy. Thanks for showing that one to me. But thank you for it being a big question, because I think it emphasises the importance of it. So look, a little bit aligned to how I answered the first question, which is how are we going to go forward? And the essence of my answer was government is needed. We must continue to work with government and encourage government, but we've got to get on anyway. I think where we need to go to with this is to keep these reports, and in particular the compassion, well, not in compassion first, but also connected and compassionate, which is the recommendations, and shifting the focus front of centre for us as a sector and as a collective. We need to actually keep them alive, because where these reports go wrong is that they go into bottom drawers and you look at immediate response and then you forget it. Actually, we need to formulate structures, mechanisms, opportunities for doing regular check-ins. And my firm belief, Lucy, is that if we commit to doing that, and if we do it, we will have to have that voice of lived experience coming through. And I think another thing that we all recognised, both at the expert advisory group and Jaylee and I, in a lot of discussions we had, was that disproportionately impacted priority population groups will change over time. They will change over time. If they don't, then we're not doing something right. So actually that criticality of embedding lived experience is just something we must work at. So I know that may sound a little bit like a fudgy answer, what are we specifically going to do? But I think the single most important thing is we must do things and we must continue to monitor them against these reports. So that is something we can and will do.
Thank you, Christine. And look, I think the energy that's come through in our work and that can be seen in the discussion today really shows to the power of that. And if I could just add to Alan's answer around data, again, a lot of these things will be resolved at a co-design level. If we are working with people in our communities, we will know the information and the data that is required to design a community appropriate service. There was just another question that popped up that I think would probably be relevant to others. Christine, if you might just talk to this quickly before we close on how those connections are going to happen with the state strategies and programs.
Yep. Okay, so, and I think that's another very good question, because people will be aware that we have moved into, we used to have quite a defined set of committees that govern all interactions between the Commonwealth of States and Territories. We've moved into a new world. If you use the two words National Cabinet, that kind of captures it. So I think the first thing and the most critical important thing is that the government, that all governments are working towards a national partnership agreement on mental health and suicide prevention. So that needs to be landed by November. And all First Ministers agreed to that. They got together in December just before Christmas at Federation Reform Council, and they all committed to the fact that national agreement would be in place by November this year. So I think keeping things simple, the KISS principle, we need to actually get that agreement in place, because that then gives us the structure whereby we can say we now have validated the fact that we can't do this in a silo way. All governments need to be brought to the table. Then there are a number of, at a sort of intergovernmental level, there are a number of touch points which already exist. And I think it's as simple as building into those meetings and those already touch points that Alan referenced when he was talking about shifting the focus, how we can work across the government. So when it comes to the Pandemic Mental Health and Wellbeing Response Plan, there is a group of us that regularly got together, and we will continue to get together to say, what do we need to do? Let's bring it into there. The mental health commissions from around the country get together every month. What can we do through that environment? So I think it is looking for our national touch points and making sure we take these documents, and these documents don't belong to us, to the task force, they belong to you, to all of you. So take them, use them, where you have any interactive relationship and networking, particularly if it's across borders or across groups, take these and use them. Because actually, as I said in my first response, if we just wait for government to act, we'll miss opportunities. Whereas if we start to implement them in whatever way we can, we will build a momentum that government won't be able to ignore.
Thanks, Christine. And I think we might seek to wrap it up there and thank, the 300 plus people we had at one stage, because I do see people ticking off and I guess they have other commitments they need to get to. We will post the answers on the website. The reports are on their website. This recording will be available on the website. And so please, as Christine said, take it all, use it as widely as you can. I do hope that the takeaway for people today and from all the work is really around that shared understanding that we tried to capture in the essence of all the reports and the work. And that leaves you with a sense of hope. And I think really, Elle, you said it so beautifully earlier when you said that this is more than a quality of life improvement. It has to be a quality of life improvement. Prevention is more than just stopping the negative. And I see that hope in the report. And I think that's something that we need to draw out and share in our communities and the work we do in prevention, that it can start right upstream. It can be in the crisis, but it's really about that, creating hope and uplifting people to a greater quality of life. So thank you all very much for joining us today. Thank you particularly and congratulations to Christine and the task force team led by Jaylee, an incredible piece of work, a groundbreaking piece of work that is really leading not just national dialogue, but international dialogue. And thank you all for joining us today.